Welcome to the first section of Chapter 5, Gastroenterology. In this section, I'll be providing an overview of the gastrointestinal system. We'll start with the oral cavity and move down to the large intestine. Let's get started. Before we jump into the physiology, let's briefly review the anatomy. This is figure 5.1 from your text, which provides a nice overview of the GI anatomy. I'm not going to read this to you, but notice how food moves from the oral cavity down to the large intestine, or the colon. Eventually, food moves up the ascending colon, down the descending colon, and out the rectum. If you're unfamiliar with the anatomy here, pause the video and take some time to commit this to memory. The first topic is the oral cavity. For step 1, you need to know that alpha amylase is an enzyme secreted by the salivary glands and begins the digestion of starch. You also need to know that the salivary glands produce a protein called R protein, which promotes the absorption of vitamin B12. We'll talk about vitamin B12 in a lot more detail in a minute. Okay, after food is chewed and moved to the back of the pharynx, the pharyngeal muscles contract, which initiates swallowing by moving a bolus of food into the esophagus. Once the food enters the esophagus, peristalsis assists in moving the food to the lower esophageal sphincter, or LES. Recall that peristalsis refers to the involuntary contraction and relaxation of smooth muscle, which produces wave-like movements that push the bolus of food forward. At this point, the LES must relax in order for food to move from the esophagus into the stomach. Okay, with this in mind, let's do a few questions. What is the underlying cause associated with formation of a Zenker diverticulum? Okay, a Zenker diverticulum is a herniation or outpouching of tissue near the pharynx and esophagus. So a diverticulum is just a blind tube coming off the GI tract. If this is the esophagus normally, then a Zenker diverticulum would look something like this. In a Zenker diverticulum, the pharyngeal muscles have difficulty relaxing and are also spastic. This motor abnormality results in increased intraluminal pressure within the pharynx, causing herniation of the pharyngeal mucosa, resulting in a diverticulum. So dysmotility causes increased pressure, which results in mucosal herniation. Patients with the Zenker diverticulum will often complain of difficulty swallowing because food can get caught in the pouch and then rot, which results in bad breath, or halitosis. Okay, let's do another question. What disorder results in a decreased ability of the lower esophageal sphincter to relax? When the LES cannot relax properly, this is known as a disorder called achalasia. Normally, inhibitory ganglion cells present in the walls of the esophagus inhibit contraction of the LES, thus allowing the LES to relax so food can pass from the esophagus into the stomach. So, ganglion cells inhibit lower esophageal sphincter contraction. Achalasia is caused by a decreased number of inhibitory ganglion cells within the walls of the esophagus. This means the lower esophageal sphincter, or LES, contracts more than normal, which prevents the passage of food from the esophagus into the stomach. So increased LES contraction. Okay, let's do another question. What is a disorder associated with a transient decrease in tone of the LES? Okay, this is essentially the opposite of the last question. Let's draw this out. This will represent the esophagus. Right here will represent the lower esophageal sphincter. If the LES doesn't contract enough, so it's too relaxed, then acid from the stomach can pass up into the esophagus. This is a disorder known as gastroesophageal reflux disease, or GERD. Okay, the next topic is the stomach. This is figure 5.2 from your text, which provides an overview of some of the gastrointestinal hormones associated with the stomach. Notice that the stomach has several important landmarks: the cardia, the fundus, the body, and the antrum. Also, it's not on this image, but the pylorus is right here. Okay, with this in mind, let's briefly talk about each of the hormones associated with the stomach. The stomach has 6 important cells that you need to be familiar with for step 1. These include the parietal cells. These are located in the body of the stomach. Also notice that the parietal cells secrete hydrochloric acid, which is responsible for the acidic environment in the stomach, and intrinsic factor, which is necessary for the proper absorption of vitamin B12. As you can see, the chief cells are also located in the body of the stomach and secrete pepsinogen. Pepsinogen gets converted into pepsin when it comes in contact with the acidic environment of the stomach. Pepsin is an enzyme that is involved in digesting proteins, which we'll talk about more later. Notice that the mucus cells, the G cells, and the D cells are all located in the antrum of the stomach. The G cell is responsible for producing gastrin. Through a chain of reactions, this eventually stimulates the parietal cell to secrete acid. The mucus cell is responsible for producing mucus, which makes sense, right? And the D cell is responsible for producing somatostatin. And this is a hormone that essentially shuts down the GI tract. We'll talk more about somatostatin later in the chapter. Finally, the gastric stem cell, which can't be seen in this figure, is located in the base of the gastric pit and is responsible for replenishing the gastric epithelium. In fact, this principle of gastrointestinal stem cells being located in the base of the crypts holds true throughout the GI tract. For step 1, you need to know that the crypt is where replication occurs the most. This makes sense. The stem cells need to constantly replicate in order to replenish the epithelium, which is constantly being sloughed off and excreted with feces. Okay, with this in mind, let's discuss the primary functions of the stomach. Okay, the stomach has 3 primary functions. The first and the only essential function of the stomach is to produce intrinsic factor. Let's pull up figure 5.3 and talk about this more before we move on. This is figure 5.3 from your text, which shows how vitamin B12 is normally absorbed. As I mentioned earlier, R protein is produced from the salivary glands. When B12 from animal protein enters the stomach, the acid, along with pepsin, separates the protein from vitamin B12, which allows R protein to bind to vitamin B12. Once the R protein B12 complex reaches the duodenum, pancreatic proteases separate the complex. Intrinsic factor, which is produced from the parietal cells, travels down into the duodenum, which can then bind the free vitamin B12. The intrinsic factor B12 complex then travel to the terminal ileum, or the distal ileum, where vitamin B12 is absorbed. For step 1, you'll most commonly see questions about parietal cell damage or damage to the terminal ileum. Both of these scenarios can result in vitamin B12 deficiency. Recall that vitamin B12 is necessary for a healthy nervous system, so a B12 deficiency can result in damage to the nervous system, which we cover in more detail in the chapter on neurology. The second function of the stomach is to act as a reservoir for food. By acting as a reservoir, the stomach can regulate how frequently boluses of food enter the duodenum. The last function of the stomach is the secretion of acid by parietal cells. For step 1, you need to know that acid secretion occurs in 3 phases: the cephalic phase, the gastric phase, and the intestinal phase. Let's pull up figure 5.4 so you can see what's going on. This is figure 5.4 from your text, which shows how acid is produced from a molecular level. The cephalic phase is mediated by the vagus nerve and is triggered by the taste, sight, smell, and thought of food. When the vagus nerve is stimulated, it releases acetylcholine and gastric releasing peptide, or GRP. Acetylcholine stimulates the M3 receptors on the parietal cells, and GRP stimulates G cells to secrete gastrin. Gastrin then stimulates the CCKB receptor on the parietal cells, and the ECL cells, or the enterochromaffin-like cells. The ECL cells secrete histamine, which can then stimulate the H2 receptor on the parietal cells. All of these transmitters cause stimulation of the GQ and GS secondary messenger pathways, which ultimately causes activation of the hydrogen-potassium pump, resulting in the secretion of acid. For step 1, you need to know that cutting the vagus nerve fiber endings near the stomach can reduce acid secretion, which should be clear now after going through the normal physiology. So what I just described was the cephalic phase of acid secretion, and this is all mediated by the vagus nerve. The second phase is called the gastric phase. The gastric phase occurs as a result of food entering the stomach, which causes the release of gastrin. Again, gastrin stimulates the CCK-B receptor and the ECL cells. The ECL cells release histamine, which stimulates the H2 receptor and ultimately results in the secretion of acid. Okay, the final phase of acid secretion is called the intestinal phase, which occurs when protein enters the duodenum. Initially, this phase stimulates acid secretion, but the overall effect is to reduce acid secretion. Acid suppression occurs when the ileum and colon release peptide YY. Peptide YY inhibits the ECL cells from releasing histamine, so decreased histamine. If histamine is decreased, then the H2 receptor is not stimulated as much, which results in decreased acid production. So remember, acid secretion occurs in 3 phases: the cephalic phase, the gastric phase, and the intestinal phase. Okay, with this in mind, let's do a few questions. Which cell is inhibited by omeprazole? So this is figure 5.5 from your text, which shows a histological image of the stomach. The pink cells right here are parietal cells, and the darker cells here near the bottom of the image are chief cells. Recall that omeprazole is a proton pump inhibitor, or PPI. PPIs work by blocking the hydrogen-potassium ATPase pump on parietal cells. So this region is blocked by omeprazole, which is a PPI. Okay, let's do another question. A 36-year-old female presents with a 6-month history of fatigue. Her mean corpuscular volume, or MCV, is 124. The physician believes her symptoms are due to an autoimmune disorder. What is the most likely diagnosis? Okay, from the question stem, we know that the patient has a MCV of 124. This should immediately make us think of macrocytic anemia. Recall that macrocytic anemias are diagnosed when the patient has an MCV greater than 100. There are several potential causes of a macrocytic anemia, but the question stem also states that the physician believes her symptoms are due to an autoimmune disorder. An MCV of 124 that is due to an autoimmune disorder should make you think of pernicious anemia. Pernicious anemia occurs when antibodies attack the parietal cells. When the parietal cells are damaged, they can no longer secrete intrinsic factor, which results in vitamin B12 deficiency. If B12 is deficient, then blood cells can't develop properly, resulting in a macrocytic anemia. From figure 5.3, we can see that damage to the parietal cells would result in loss of intrinsic factor, which would prevent the proper absorption of vitamin B12. Okay, let's do another question. How would pernicious anemia alter gastrin levels? Okay, from the last question, we know that pernicious anemia is a result of autoimmune destruction of the parietal cells. This damage results in decreased hydrochloric acid secretion. As the pH rises in the stomach, the G cells detect the decreased acid and begin to release gastrin and attempt to stimulate the parietal cells to secrete more acid. So, decreased parietal cells results in decreased acid, which increases the G cells' production of gastrin. So how would pernicious anemia alter gastrin levels? They would be increased. We'll talk more about gastrointestinal hormones later in the chapter. Okay, let's do another question. What is the only essential function of the stomach? Okay, pretty straightforward. I just want to reinforce the idea that the only essential function of the stomach is to produce intrinsic factor. If the stomach is removed, then the patient will develop vitamin B12 deficiency. If this occurs, then high doses of vitamin B12 must be administered throughout the patient's life in order to overcome the loss of intrinsic factor. Okay, let's do another question. A patient has a gastrectomy due to gastric cancer and the esophagus is directly sutured to the duodenum. The patient is prophylactically given high doses of vitamin B12 to prevent anemia. What other symptom is the patient likely to have? Okay, from the question stem, we know that the patient had a gastrectomy, and the patient has been prescribed high doses of vitamin B12. So we don't have to worry about the patient developing anemia. The question asks what other symptom the patient will likely have. The key to getting this question right is remembering that the stomach acts as a reservoir for food and regulates how frequently boluses of food enter the duodenum. If the patient doesn't have a stomach, then large boluses of food can directly enter the small intestine, resulting in a high osmotic load to the GI tract. The high osmotic load can pull in water, which can cause diarrhea. So increased osmotic load results in increased water in the gastrointestinal lumen, which results in diarrhea. Okay, let's do another question. A 4-week-old boy presents with non-bilious projectile vomiting. How will this disorder alter his electrolyte concentration? Hopefully from the question stem you notice that the patient has pyloric stenosis. Pyloric stenosis occurs when the pylorus becomes narrow, which prevents food from moving from the stomach into the duodenum. As food accumulates in the stomach, the child develops projectile vomiting. It's non-bilious because the food hasn't passed into the duodenum, which is where bile enters the GI tract. The excess vomiting results in the loss of stomach acid. Recall that stomach acid is in the form of hydrochloric acid, so HCl. This means the patient will lose hydrogen ions, so decreased hydrogen, resulting in an alkalosis. The patient will also lose chloride, resulting in hypochloremia. So the patient will develop a metabolic alkalosis with hypochloremia. Okay, the next topic is about protective factors that allow the stomach to withstand the presence of such a highly acidic environment. There are 4 important factors you need to be familiar with for step 1. First, the stomach is highly vascularized, which allows blood to sweep away acid that may come in contact with the gastric epithelium. Second, the mucus cells of the stomach produce a thick mucus barrier between the acid and the gastric epithelium, which prevents the acid from eroding the tissue. Third, the gastric epithelium secretes bicarbonate into the mucus layer, which neutralizes the acid that reaches the mucus barrier. Finally, other influences, such as prostaglandin E, can increase the production of bicarbonate and mucus production. Okay, with this in mind, let's do a question. How can H. pylori cause damage to the gastric mucosa? Okay, recall that H. pylori is a bacterium that commonly invades the stomach and can cause ulcers and gastritis. For step 1, you need to know that H. pylori produces the enzyme urease. Urease normally converts urea into ammonia. The ammonia gets converted into ammonium in the acidic environment of the stomach. The ammonium is toxic to the gastric epithelium and can disrupt the normal mucosal barrier. Over time, the stomach becomes damaged, which can result in ulcers and inflammation of the stomach, or gastritis. Okay, let's move on to the small intestine. From figure 5.1, we can see that the small intestine is right here. This includes the duodenum, the jejunum, and the ileum. This is where a lot of important digestion occurs, so we'll discuss this more in the section on digestion and absorption. After food passes through the small intestine, it enters the colon, or the large intestine. The last topic is the large intestine. For step 1, you need to know that the normal flora produce folate and vitamin K from undigested sugars and also protect the mucosa from pathogenic bacteria. It's also worthwhile knowing that the large intestine is especially prone to developing diverticula when intraluminal colonic pressures increase. As I mentioned earlier, a diverticulum is just a blind tube coming off of the GI tract. Okay, let's wrap up this section with a couple more questions. A patient is prescribed antibiotics for suspected strep throat. The patient also takes warfarin due to a history of blood clots. How will the warfarin dose likely need to be altered due to the new prescription of antibiotics? Okay, this question ties together a lot of physiology and pharmacology. Let's break it down. For step 1, you need to know that the administration of antibiotics can disrupt the normal colonic flora. As we just learned, the normal flora produce vitamin K. You also need to know that warfarin is a drug used to treat patients with excessive coagulation problems, such as heart attacks, strokes, or pulmonary embolisms. Warfarin works by inhibiting the enzyme epoxide reductase. So warfarin inhibits epoxide reductase. Epoxide reductase normally converts oxidized vitamin K to reduced vitamin K, which can then be incorporated with coagulation factors necessary for the coagulation pathway. So incorporated with coagulation factors. So as you can see, warfarin inhibits epoxide reductase, which ultimately prevents the incorporation of reduced vitamin K into coagulation factors. In this way, warfarin works as an anticoagulant or blood thinner. So this ultimately inhibits coagulation. If less vitamin K is available because colonic bacteria are killed, then that means less warfarin is necessary in order to achieve the same anticoagulative effect. So antibiotics results in decreased colonic bacteria, which results in decreased available vitamin K, which means we need less warfarin in order to achieve the same effect. So how will the warfarin dose likely need to be altered? We'll need to decrease the warfarin dose. Okay, let's do one more question. How can age increase the risk for developing diverticulitis? In order to get this question right, you need to know that age results in changes in type 3 collagen. Type 3 collagen is normally present in the colonic epithelium, so age can disrupt the normal colonic wall, resulting in weakness. As the wall becomes weakened, it's more prone to developing diverticula, and if fecal contents become impacted in the diverticula, then the patient can develop diverticulitis. So increased age results in decreased type 3 collagen, which results in increased wall weakness, which results in increased risk for diverticula. And as the patient has diverticula, their risk for diverticulitis increases. It's important to know that increased intra-abdominal pressure contributes to the development of diverticula. So the administration of fiber can reduce constipation and ultimately the risk for developing diverticula.